All the speakers need to come up here so we can get going before we end up behind already. How you doing? You gonna speak or come on up? Oh. All right. Yeah. Okay. Oh, if you see Dr. Ray, is Dr. Ray? Oh, okay. All right, well, why don't we get started with the next session here? Some very interesting talks. Everyone's here. We have a little change. Dr. Grayson Wheatley from Temple is going to give their first talk on Takayatsu arteritis, so we'll welcome him.
Thank you very much. Here are my disclosures. Just wanted to begin a little bit with a brief overview on Takayatsu's arteritis. As many of you know, it's a large vessel vasculitis as compared to other processes that address medium and small vessel vasculitis. Here's an example of a patient that has diffuse vasculitis, both of the great vessels, the aortic arch, ascending aorta, and descending thoracic aorta. Once again, to also put it in perspective, it is a subcategory of non-atherosclerotic occlusive arterial disease. Once again, 10% of the occlusive arterial disease are non-atherosclerotic in nature. Histopathology, there's affected by a giant cell arteritis, and you can see there all of the inflammation and pathophysiology for the occlusive disease. There are a number of different clinical findings associated with Takayatsu's arteritis. And as you can see here, it ranges everything from diagnostic clinical information, such as elevated SED rate, all the way to symptoms such as headache, tenderness of the arteries, jaw claudication, and other associated symptoms. There are a number of different classification systems, but all of them center around different anatomic regions and associations and presentations. The type 1, the classic Takayatsus that we saw in the previous image, you can see there as a type 1. Type 2 is isolated into the descending thoracic aorta and abdominal aorta. Type 3 involves the great vessels and ascending aorta. And then type 4, believe it or not, actually involves the pulmonary arteries. Another classification system is a little bit more segmented. There are 5 different variations. And then these patients also are subclassified as C+, meaning involving the associated coronary arteries, and or P+, which involves the pulmonary arteries. But that is the kind of the general classification system. Here's another radiographic example or angiographic example of a patient with, you can see there, occlusion or loss of the left common carotid artery associated with their disease. Here's another example of a patient with the loss of the left subclavian artery, an isolated branch of the great vessels. You can see that's being affected. It generally presents in the second and third decade, may range, of course, earlier and later in life. And there are different genetic variations regionally. It can affect any type of race and population. We've all known that it's affected more Asian and Indian in general, but it does affect different presentations. You can see that there are some gender differences even amongst different races, with Japanese, with the female to male ratio 8 to 9 to 1, versus an Indian almost 1 to 1 and 3 to 1. There are a number of different genetic haplotypes involved with this. As you can see, it's a range of different presentations. It's an association of wall thickening, fibrosis, stenosis, and thrombosis, ultimately resulting in end-organ ischemia, and these stenotic lesions often tend to be bilateral. Here's another radiographic example of a patient with the Takayatsus, and there's some general manifestations, as we said: fever, weight loss, headache, with the late ischemic phase involving diminished or absent pulses, bruits, hypertension associated with renal artery involvement, and diffuse involvement. So here's some more pictures. You could see it can be situationally one vessel, multi-vessel. You could see it could be focal, it could be diffuse, and there are a number of different classification systems. This is the most commonly recognized American College of Rheumatology based off of a number of different criterion. And it's interesting, once again, that these presentations can be variable amongst different races. You can see that in Japan, there's less prevalence of hypertension associated with this disease, as opposed to in India, there's a much higher association of hypertension. Survival is cumulative 5 years at 91%, 10 years 84%, and that based off of the severity of the disease, you could see here that the groups 1 and 2, the ones that have just branches from the aortic arch, and ascending aorta did not have any deaths, but there was a higher mortality in diffuse or more severe penetration. You can diagnose this with MRI, and you can see here's 2 examples of a patient that has active phase, and you can see the actual ability to describe and delineate it on MRI. You can see mural thrombi, you can see a signal attenuation, vascular dilation, as well as thickening, although it can be difficult with the small vessels with the MRI. One other interesting radiographic presentation of this is also the PET scan. As you can see here, that there is some specificity, 83% specificity, and here's a patient that had a PET scan, can pick up this diagnosis, and here's another example of how you can pick this up. Of course, medical therapy is instituted for the active phase, but once patients have occlusive or thrombosis, then there's indication for surgery or endovascular intervention. And here's another angiographic picture. So you can see that basically there are options, balloon angioplasty, as well as balloon angioplasty and stent-supported treatment. One of the earliest findings of this was in 1993. Here's a small study of 16 patients, showed that it was actually technically feasible. 100% of the patients were able to be treated. There was a 67% patency at 52 months with some extended follow-up. So I want to kind of wrap up or begin to discuss many of the published literature. There's no large series. It's a lot of a small series. And here's a study out of Korea with a subset of patients that had Takayatsu's arteritis by the classification, and they treated 218 patients, and you could see ranged anywhere from the nominate, common carotid, subclavian, and internal carotid with a host of different presentations. And you could look at the results of 15 patients treated surgically versus 10 patients treated endovascularly, and there was a very even distribution for demographics. And when you look at the outcome of the surgical group, you could see that in the 15 patients, they had pretty good early success with decreased risk. And then in the endovascular group of 10 patients treating 15 arteries, there was a similar technical success and similar results. And the authors in that paper said that the treatment from an endovascular standpoint or from a treatment standpoint is associated with a higher risk of restenosis or occlusion than bypass surgery, even after postoperative anti-inflammatory treatment. So the endovascular treatment doesn't quite seem to have the durability that an open surgical approach has, but technically very feasible and has some potential. One of the best papers, I think, in the literature right now is the paper from Greenberg's group in Cleveland Clinic, and they had a small series of patients, and they reviewed their outcomes and talked about their Cleveland Clinic experience. And they had, you could see here, a host of different treatments, bypass, angioplasty, on a number of different arterial segments, 21 in the surgical group and 18 in the angioplasty group. And you can see the patency was 61% in the surgical group, 22% in the angioplasty group. So once again, kind of speaking to that discrepancy in patency rates. They reviewed the literature and said that when compared with atherosclerotic lesions, the rate of intervention for Takayatsu's had a greater rate of graft failure, which does become concerning. But you actually have to treat these patients in the non-active phase, so it's really important to treat them medically before you intervene. And they said that in also reviewing the literature and that long-term follow-up has been disappointing as compared to other atherosclerotic lesions, and the differences might be explained by several factors unique to Takayatsu's arteritis. And unlike atherosclerotic lesions, the vessels are firm, scarred, and fibrotic. the effective lesions are no longer than atherosclerotic lesions, which tend to have incomplete dilation and are associated with a higher rate of restenosis. One of the interesting comments they had in this paper, and I guess intellectually this makes a lot of sense. You could imagine the trouble with treating this pathophysiology with just angioplasty or an uncovered stent. But what about the use or involvement of covered stents to treat these patients? And they had two hypothetical advantages, and they did see an advantage in patients where they used a stent graft to treat the disease. And the first hypothesis that they had was that the stent grafts decrease the chronic inflammatory aspect of the inner layer of the vessel wall, because the fabric is then causing some ischemia, so to speak, or depriving the inner layer, the intima, from a vascular revascularization, and perhaps maybe treating the disease from that standpoint. And then, of course, the other is that the covered fabric does help from preventing myointimal inflammation and ingrowth that you might have with an uncovered stent. So they did see some improvement and benefit with the outcomes with their covered stent grafts. And here you can see that in their conclusions, I think was really important to say that the long-term data, as we know, is really not there, and it may be beneficial, actually, to salvage surgical grafts with the endovascular approach, maybe not as a standalone, and that may be another way to increase the durability. And it's very important, once again, to treat these patients in the non-active phase of their disease, treat them medically first, and then treat the complications of the disease. One of the complications, of course, for these patients are twofold. One, you have a recurrence with in-stent restenosis just by nature of the pathophysiology. But then you also have some actual structural integrity of the stents can be lost due to the aggressiveness of the pathophysiology and the interaction with the stents, and that may be a little bit more substantial than standard atherosclerotic patients just because of the nature of the pathophysiology. And finally, when we talk about just in addition to the great vessels themselves, you can also talk about this from an aortic standpoint or a patient standpoint. And because these patients have a diffuse presentation, you could see that it sometimes becomes feasible and necessary to treat the aortic disease, and that patients have been treated with endovascular aortic stent grafts successfully, and that's an option in addition to the great vessel localized intervention. So in conclusion, endovascular interventions for Takayasu's arteritis are technically feasible. It's indicated primarily for symptomatic patients that are in the latent phase or in the non-acute phase of the disease. Patency is generally less than surgical bypasses. There is some perhaps benefit of stent grafts, but we need some additional follow-up, and is good for salvage of open surgical grafts that become occluded after the initial surgery. Interventions should be reserved for patients not in the active phase, as I said. We need longer-term follow-up, and we need to certainly better understand this disease and understand which patients are better treated surgically versus endovascularly. Thank you very much.
Thank you. That was an excellent review. Next, we'll have Dr. Archer from University of Wisconsin-Madison. He's going to talk about something we hope we never see, and it's infected endografts.
Thank you. And let me just figure out this thing. It's this one that advances? Yeah, okay. So I've been given the task to talk about something you never want to see, but unfortunately, occasionally we do. I'll be presenting some examples of all kinds of graft infections, but also endovascular, primary infections of the aorta, because some of the same principles are applicable. I have no disclosures. The data for sources for this talk come from a statewide database, Washington State, the National 17 Hospital Consortium database, institutional databases, and the National Inpatient Sampling Database. So a lot of national samples, a lot of large data sets to look at this problem. The goals of this talk are to talk about prevalence, diagnosis, associated factors, treatment options, outcome expectations, and perhaps prevention. So prevalence. The incidence is low, fortunately. However, there are a couple of factors that increase the risk. with the initial procedure, and that is if there's septicemia or a surgical site infection. Although the risk is low, it's significantly increased over the risk if you don't have those things. The average time to diagnosis, that's supposed to be 28 months, and it's earlier for endovascular aneurysm repair as opposed to open aneurysm repair, and I think this is primarily because we follow the endovascular repairs more frequently, and probably they're picked up earlier. The bacteriology is single organism in most cases, but when you have graft enteric erosion, it's polymicrobial and fungal. One of the important things to remember is that these patients with any kind of aortic graft are at risk for their entire lives, as you can see from this graph, even out to 15 years. And that hazard remains with the patient as long as they're alive with that endograft, or surgical graft for that matter. And this shows the hazard with and without a nosocomial infection at the time of their initial procedure. And I think one of the things you have to, in these patients, you can see the ones that had a nosocomial infection, their risk is increased over the years. And this may be a manifestation of a primary immunologic issue with this patient, as well as the present, which predicated the nosocomial infection to begin with. So symptoms, half the patients, more than half the patients have pain, half have fever, weight loss, and a surprisingly number of endovascular infections have enteric fistulas. Now, it may be a graft enteric erosion, or it may actually be a fistula with bleeding. And some of them, many of them, are indolent and actually picked up on CT scan without the patient necessarily being sick. These are the odds ratios for associated factors, and it's important to notice that patients with EVAR are equally at risk as patients with open repairs. But the big thing to take away from this is that nosocomial infections at the time of the initial procedure increase the risk, and the odds ratios for a bloodstream septicemia increase it by 4.2, and surgical site infection increases the risk of the subsequent infection by 6.8. In treatment, what makes endovascular repairs different than open repairs? It's really the problem of fixation. And it's because, as you can see from an EVAR, if we do the optimal placement, we're from just below the renals to the bifurcation of the iliacs, internal and external iliac, to get maximal fixation. But this also means that to go in and take this graft out, it's more complicated. The fenestrated grafts and branch grafts make it even more complicated because of their position. TVARs actually have a very miserable outcome in treatment when they're infected, and I'm not going to get into that. But what makes endovascular different is that the arterial wall is so involved with the graft. With an open repair, you sew end to end. With an endovascular repair, your graft becomes embedded in the wall, whether it's the iliac or the proximal aorta, and that leads to an arterial wall infection, or a mycotic arteritis, which makes it technically really different. So what are the ways we treat? Preservation with and without drainage. It's by and large done in patients who are too sick to do anything with. In situ replacement with Dacron, PTFE, or cryohomograft, and graft excision with extra-anatomic bypass. And sometimes we do a temporizing procedure for exsanguinating hemorrhage from a fistula with an endocuff, which is more difficult with endo than it is with an open repair because the neck is usually shorter. So 90% of the endografts that become infected are done with in situ replacement. 4% are preserved, and the extra-anatomic is about 6%. And here's the mortality, 30-day mortality, and this is multiple series sort of average, runs around 20%. The 1-year graft-related mortality is pretty high, 30%. And the 30-day mortality, if we leave the graft in, is 50%, and I'd say the 1-year mortality is much higher, although there's not a lot of data. 12% of the replaced grafts are removed because of continued or recurrent infection. And you have to imagine that that's in the ones that are strong enough to really consider that. And here's the survival and graft-related mortality over time. And I would say that in this particular paper, the graft-related mortality is probably underestimated. And if you look at the first-year mortality of 28% overall, that most of that is probably graft-related. But their definition of that, I think, made their data look a little more favorable. So what does an infection look like? So here's an aortoduodenal fistula with infection. You can see from the CAT scan that there's air inside, and this is a standard repair, air inside the graft. But more importantly, the duodenum is adherent directly to the aorta at the anastomotic interface. And this patient did not have a major GI bleed, but presented with fever and white count, and was treated with removal of the graft and an AX-Fem bypass. Another presentation is acute exsanguinating hemorrhage from an aortoenteric fistula. As in this patient, you can see the sort of large outpatching at the anastomosis. Sometimes it's possible to treat this with a cuff to stabilize the patient, and then later go back and do an in situ repair or remove the graft, as we did in this patient, with an extra-anatomic bypass. Occasionally, you'll see a patient that has a massive infection, and this is a patient with a primary aortic infection, but it's similar if you have an endograft in that there's so much infected and necrotic debris that in situ replacement is problematic, especially if it's a bad organism like methicillin-resistant staph, which has a very high risk of recurrent infection no matter how we treat it. One of the techniques you can use in this situation is to remove, debride all the infected material, reconstruct the aorta, do an extra-anatomic bypass usually first, reconstruct the aorta, or reconstruct it and put an in situ graft in. As in this patient we did, and this is a CT angiogram 8 years after surgery with the AX-Fem in place and a stable aortic architecture. So PTFE, E. coli, is generally considered a bad organism because it's a gram-negative. In this patient with an E. coli septicemia from a urinary tract infection, and this is one of the principles. If your aorta, whether it's an endograft or a primary infection or an open, if you have an endovascular infection in the aortic wall, you have to remove all that wall. You have to debride it. If you don't, you'll have recurrent infection. And so this patient was replaced with a PTFE graft, which is actually my graft of choice for infected situations, and was a long-term survivor without recurrent infection. Cryohomograft is another very viable source in this patient who had strep pneumonia. And strep pneumonia is an organism which you can probably use a synthetic graft for because it's easily treated with antibiotics. In this patient, we used a homograft for some technical reasons and replaced, as you can see on the right, from the renals down to the aortic bifurcation. In patients who have massive bony destruction and a large infected space, cryohomograft can be very, very effective. if their reinfection risk is high. In this patient, a year after surgery, the mesenterics had a little stenosis, which we treated with angioplasty and a covered stent. So in conclusion, it's a low incidence, but a high morbidity and mortality associated with endovascular graft infections. Remote infections and periodontal disease play a major role in these infections. Graft enteric erosion is more common than you would think. In situ treatment fails most of the time, and Dacron has the highest recurrent infection risk. Cryohomograft and graft removal with extra-anatomic bypass have the lowest risk of recurrent infection. Thank you very much for your time.
All right, excellent. Thank you very much. That was an excellent review. Next, we have Dr. Ree, who's going to talk to us about the pesky hypogastric artery. Keep it or lose it. Just advance with this one.
Thank you. I'd like to thank the organizers and Dr. Jones for inviting me again. I think the title is preloaded, so I was assigned this title, and I had sort of a premonition about the perspective that this group had, but I'll try to keep it unbiased as possible. So these are my disclosures. So iliac artery aneurysms, EVARs, are complicated because of the landing zones distally, and that's basically what I'm going to be talking about. It requires a lot of thinking and pre-planning, and often multiple surgical teams are required for successful intervention, even with the branch grafts. Now, the issue really is, can we sacrifice the pesky hypogastric artery? Do we really need it? Can we just ignore it during EVAR? Well, there are clearly documented complications of intentional occlusion or unintentional occlusion. Claudication, colon ischemia, spinal ischemia, sexual dysfunction, buttock necrosis, and even deaths at times. Some or none of these complications can occur with many of these procedures, but the options are open repair, hybrid repair, if we have iliac artery dilatation, or endovascular repair, involving either sacrifice of one or both of these internal iliac arteries. Well, the short answer to the pesky question, contrary to our famous Dr. Veith, who claims that you don't really need them, is my perspective is save them if you can, if possible. The gold standard is open repair, and when we were first starting out with EVAR therapy, if we had iliac artery aneurysms, generally we opted for open repair. But that was back then, and now is now. And with our technologies, we can have various techniques to preserve the hypogastric. This is one of the earlier options of preserving the hypogastric artery by doing a retrograde perfusion, by doing an aorta uni with a fem-fem, or doing a retrograde bypass with a Viabon after doing the fem-fem. Either way, you're trying to preserve at least one of those pesky arteries. The current endovascular devices, we heard a lot about what to do with the neck, but the distal landing zone still remains a problem for many of our patients, especially in the New York area. We have a lot of patients with concomitant iliac artery problems as well. And really the best way to treat these, as with the neck problems, are with branch graft technologies, but we don't have any. Some are in trial, and I'll go over some of those devices as well. So why consider sacrificing it? Well, there's no adequate landing zone for the iliac limb. The common iliac artery is large, or you have an internal iliac artery aneurysm. Early on, and as well as the recent reports show that embolization can be quite safe. Most are well tolerated, especially with short periods of claudication, and even midterm results are good. This was one of our earlier papers saying that we looked at our hypogastric embolization experience, and we advocated that you can do this with minimal consequences. And this is our original series on 49 patients that we did, and we coiled them, we put amplets or plugs, and this is some of them early on we actually did bypasses if we didn't want to sacrifice both. The results were pretty good. All the bypasses were patent. All the occlusions remained occluded, but many of these patients had sequelae. As you can see, if you had bilateral internal iliac artery embolization, 33% had initial claudication, and 17% had permanent claudication, and even one patient had severe buttock necrosis, which is incredible. And once you see one of those, you don't want to ever see one of those again. So it's not without consequence. So our general philosophy at our aortic center is to preserve at least one, if you can. And recent reports, this is a large group from Korea, over 100 patients, showed that embolization prior to EVAR is not a benign procedure. In fact, up to 30% of these patients actually had permanent claudication symptoms. So the idea is to preserve it. And since we don't have any branch graft, the first way to preserve these is really doing the sandwich technique, which was popularized by Dr. Lobato from South America. And he advocated that you can actually put in two devices into one in a sandwich. And you can do this with all types of devices. You can do it with all the currently available devices, with any kind of branch device. But really what we've been using is Viabonds from above, coming from axillary, cut down with double sheets so that you can insert the two. I'm not going to go into the details of it, but this is pretty much the sandwich procedure. I'm sure most of you have done this to try to preserve the internal iliac artery, but you do have to get arm or axillary artery access to do this. You can do this with the Endologix device without upper extremity access and going up and over through the contralateral, from the contralateral side, which is the concept for most branch graft devices, and they do pretty well, although there is a fair amount of thrombosis rate. My personal experience with only 18 patients was that we had an 83% patency. I've done it with most of the endograft systems. They work pretty well. But what the future really is that, I think that if you can save one of them, why not save both? If you need to save both. I mean, this is an artery that serves the pelvic circulation, so I think the future is to do branch grafts, and we're one of the trial sites for the Gore bifurcated, the branch graft for the internal iliac device. It's called the IBE device. It's 50 sites with about 60 to 70 patients enrolled, and it's basically like a mini Gore excluder device, which is placed in the distal segment of the iliac artery, enlarged iliac artery, to afford branch graft perfusion into the internal iliac system. And you can do it on one side or both sides. It's a staged deployment, so you can actually deploy the device and move it, just like the C3, to adjust the cannulation point. And these are the early preliminary results. Darren Schneider, who was the national PI, was kind enough to share this with me. All the enrollment is complete, and the 5-year follow-up will occur, but the FDA submission will occur sometime in the fall for this. So you will soon have access to this device, sometime probably next year. The results were very good. The technical success rate was close to 100%. The site-reported data, not the adjudicated data, but the site-reported data shows at 1 month and 6 months at 55 patients, showed no type 2 endoleak, 1 claudication symptoms, most likely related to one of the 3 internal iliac component occlusions. Only 1 intervention in terms of a type 2 endoleak was required. Now, this device was put into trial in 2013, but was CE marked in Europe, and Europeans have put in over 500 of these cases of these devices already. So we're, as usual, in the United States, we're a little behind, but they've had very good results with minimal internal iliac component thrombosis. This is one of the last cases we did. This is a trial patient that we did a bilateral iliac on. This large aneurysm, the common iliac arteries were enlarged, so we decided to preserve both. And this procedure is relatively simple. You put up the device, you snare a precannulated gate, and then you place a 12 French sheath up and over a 12 French Cook flexor sheath, which is very adaptable for this purpose, and then you just deliver the internal iliac component through a precannulated device, and the device can be lined up very easily. This procedure on a unilateral situation adds maybe 15 minutes to an EVAR procedure. And this is both devices going in, and the completion is, what you're left with is complete revascularization of the internal iliac arteries with exclusion of the aneurysms. And really, if you think about it, if you can do it, why not do it? And why subject the patient to claudication symptoms? So this device should be, as with the Cook device, should be available sometime in the next quarter or so. And this is the post-completion. We've only enrolled 3 patients, but in the trial, but these patency are remarkable. When you see them, they're much more robust than the Viabond sandwich grafts. This double bifurcated branch graft only actually took 30 cc's of contrast, because we did it all under CT guidance with CT imaging. So the fluoro time was minimal. It doesn't add that. The point is that it doesn't add a lot to the actual EVAR procedure. This is the Cook Zenith branch device, which I had put in several when I was in Pittsburgh, and it's also currently in trial. The delivery system is very similar as well. So it's a pre-cannulated system that you develop, that you deliver up and over the bifurcation, again, without upper extremity access. So the conclusion for this pesky question is that unilateral internal iliac artery or the hypogastric artery coverage is very well tolerated, but many patients do claudicate, and they will complain. But usually it's self-limited and temporary. Bilateral internal iliac coverage should be avoided. The concept of staging these coil embolization has not been proven. We generally don't stage it unless the patient, unless you want to avoid lengthy procedures, but I don't think staging really adds anything to the procedure. Internal iliac artery reconstruction is definitely possible. It's a real pain in the neck to do, but they do stay open. I think they're definitely more durable than sandwiches. Sandwich techniques are, again, like chimneys, in my opinion, are a temporary interim solution for this, and ultimately branch graft devices will be available. So the answer is, save that hypogastric, pesky as it is. Thank you.
All right, that's a great talk, and it's nice to see some innovation, some new stuff coming to help solve this, so we look forward to those being available. Okay, a little bit of change. The live case, they weren't able to turn over the room fast enough, so we're just going to keep moving and finish our talks, and I'll give us some time for questions after this. So is Dr. Jones ready, or should we go with Ross? Jones is ready, all right? Here he comes. All right, we're going to do a little complex case presentation, so come on up.
All right, thanks, Chad. We're okay with the slides back there? All right. I'm going to take advantage of our expert panelists and engage them in some discussions on a topic that I think is very interesting, very challenging. And I work in an institution, it's an inner city hospital, so-called safety net hospital, with a fairly busy ER. And I tell you, the pathology we see coming through that ER never amazes me. And I am under the impression that we get more than our fair share of complex pathology. And Ross, you're right down the street from me. and I'm just wondering if you guys are seeing just as much. I'm sure you are. But one area that I think we see a fair amount of pathology, again, more than we expect to see, is in the area of acute aortic syndromes and acute aortic pathology. And this particular case that I'm going to share with you as well as our panelists today is one of a complex type B dissection. We actually had 3 of these cases on the matter of about 6-week time period. And this is purely, obviously, the domain of the surgeons, and I've worked very, very closely with our cardiovascular surgeons, for the past, I used to say 10 years, but I guess I'm aging a bit, but we're probably 15 years. And as we all know, the volume of cardiac surgery in this country and in our institution as well is going down, down, down. And so most of our surgeons are looking for cases. But when it comes to this, I tell you, we had these 3 cases over the course of a 6-week time period, and these very, very senior, very competent surgeons was calling me and say, hey, Paul, let's get you involved. And these are cases that actually went to the cath lab or our endovascular suite rather than the OR. So I selected one case for discussion, and I wish, to be perfectly honest with you, I had the opportunity to present all 3 to this group. But time was of the essence, and I was only allowed at 20 minutes, but this clearly could be a whole afternoon symposium. But again, I think it's going to open up a number of topics of discussion. So let's just start with this presentation. Next slide. Oh, I guess that's on me. These are my disclosures. Again, they have no significant bearings on the presentation. This is a 44-year-old African-American female patient whose only known past medical history at the time of her presentation to us, as well as to an outside institution, was systemic hypertension. However, 5 months prior to presenting to us, she had presented to an outside institution with an acute aortic syndrome, was found to have a type V thoracic aortic dissection that was complicated by retrograde extension and dilatation of her ascending aorta. And she subsequently underwent open surgical repair of the ascending aorta intramural hematoma with the hemiarch repair. Did reasonably well, was discharged from that hospitalization after approximately 2.5 weeks, and apparently got lost to follow-up. And she shows up to our emergency room again about 5 months later with complaints of severe back pain, accelerated hypertension, and 1 episode of hematemesis. Her blood pressure was documented to be 202 over 116. She was a little tachycardic with a pulse of about 104, presumably related to the pain. Her physical examination was remarkable for the fact that her pulses were the same in both arms, upper extremities. There was no murmur noted on a cardiac exam. Her diagnostics included a chest X-ray, which revealed a wide mediastinum. She had a transthoracic echo as well as a CT scan. The echo revealed that the aortic valve was intact. There was no significant valvular incompetence, and her aortic root appeared to be intact as well. She had a CTA, which reveals evidence of a previous repair, as well as a large aneurysm of the descending thoracic aorta, just at the level of the takeoff of the left subclavian artery, and a type B dissection, which extended antegrade down to the level of the celiac arteries. The only other thing that was of note in her diagnostics was she had hemoglobin of about 10 with microcytic indices. Her MCV was right around 69, as I recall, and she had some mild renal insufficiency. Her serum creatinine was about 1.8. This patient obviously was managed medically, admitted to the unit, placed on labetalol drip with control of her blood pressure and heart rate. She subsequently was evaluated by the GI service because there was a question as to whether or not she had an aorta-enteric fistula causing her hematemesis. GI workup was negative. Hemoglobin remained stable. Her pain was managed with intravenous narcotics. And the question was, what do you do about the aortic pathology here? This is her CAT scan. Again, this is a transverse plane here, and as you can see here, as it scrolls through, you can see evidence of a pure aortic hematoma there. The ascending AO looks pretty decent here. This is going to loop, so we're going to be able to see this a few times. Trying to get my laser to work here. There you go. I think my battery is dying, but on this pointer, but as you can see here, the aorta below the renal arteries is very tortuous but intact. Her iliofemoral system looks pretty good. She has a large fibroid uterus there, but again, as you run this again, you can appreciate this large periaortic hematoma here, which extends retrograde to the transverse arch. You can see a dissection plane there, and as you can see going down, this is the true lumen. That's a false lumen there. The true lumen becomes a slit.
Do you see any dissection across the arch?
No, that's retrograde extension of the hematoma, not the dissection. We'll run it back again.
Do you have some sagittal views?
Yes, that's coming up next. Again, it's just a big fibroid uterus there. Thank you, sir. So again, stop. This here is just a hematoma. Again, there's no dissection there. You see, Vinny? And in terms of measurements, as you can see, the native aorta there, just the relatively healthy segment, just proximal to the left subclavian, measures about 30 to 31 millimeters. The true lumen in its narrowest portion was only about 1.6 centimeters. The false lumen ranged anywhere between 28 to almost 42 millimeters in diameter as you go out throughout the descending thoracic aorta. The visceral vessels in terms of the SMA, the renals all came out of the true lumen. The celiac, again, appeared to be coming off of the false lumen and possibly supplied by both true and false lumen, and maybe a little fenestration down there. Can we go to the next slide, please? And can we play this? So these are the sagittal views here on CT. And as you can see here, this hematoma just extending a little bit. That's the left subclavian there. But the dissection, again, is right there at the level of the left subclavian, just distal there. And as you can see, as this extends all the way down, you can see the celiac and the SMA, and that's the dissection plane kind of ends right there at the celiac artery there. So at this point in time, patient is comfortable, blood pressure's well controlled, she's pain-free, hemoglobin is stable, GI workup negative. We know that she has had that previous surgical repair of the ascending AO. So I just, at this point in time, in reference to our panelists, just opened up for comments in terms of Where do we go next? When and how? We got a lot of experts up here. She's 44 years of age. You know, it's an interesting thing about it in our institution, and Ross, I want you to chime in a little bit because you're just down the road a piece, but it seems like, as I said before, we see more of our fair share of this acute aortic pathology, and it almost always is in young African Americans, male or female, comes in with this just acute, wicked pathology, aortic dissection, complex, with or without aneurysmal degeneration. I'm impressed with the fact that there is clearly a higher incidence. Something is going on, and we need to look at it.
I mean, we actually see a lot of this in Brooklyn because of the immigrant population, and it's probably just untreated hypertension that's contributing to this. So this is actually a very typical patient who's had like a type A ascending repair, really remodels unfavorably distally and develops, whatever pathology. So I think that this is a different animal than an acute dissection. I mean, I think I've operated on acute dissections, and most of those patients don't survive. So, but this patient, I think surgical option is definitely one of the possibilities because of her age. I mean, there's definitely endovascular options, but the cardiac surgeons obviously did not want to tackle this, huh?
We can get into that discussion. Let's hear from the other panelists.
I totally agree, because if you look at the anatomical configuration of this, I think a surgical option considering age is not a bad option at all. I mean, the subclavian is fairly well preserved. You've got, I think surgery is not a bad option, but yes, endovascular is a good option, and I think this patient actually will do well with endovascular because all the vessels are coming up the true lumen. You can do a covered stent at the entry tear and then just build up with uncovered stents if the true lumen is not exposed completely or expanded completely. And I think eventually this whole area will heal with endovascular.
Ross?
So I agree with you, Paul. We see a fair share of young people with pretty bad aortic pathology, and I agree with what Rob said. I think this is due to poorly diagnosed, poorly controlled, poorly compliant hypertension, and is part of the reason why I think this type of problem is better served with an open repair long term, because when you look at the data for chronic dissections, which this would fall into this by chronology now, the number of secondary interventions required to maintain a durable result gets higher and higher, and as a young person with poorly controlled hypertension, I think the better way to treat this would be with an open surgical repair. Prior ascending is done through a sternotomy. This is left chest. This should not be an overly difficult operation in terms of an open repair for a cardiac surgeon with good aortic experience.
Miguel?
I don't think that I would go straight to surgery. I would not hesitate doing endovascular. I would put a spinal drain. I would look at the need or not to knock that subclavian off for better landing zone. If so, I do a carotid subclavian bypass and then just extend the thoracic graft. I mean, what I want is adequate apposition down to that segment. I'd probably start with something like 20 centimeter graft and then see through IBUS what the true lumen does at that point. And I think that's what I would do.
Great. Let's jump on the other side of the room here. We got some cardiologists, Jack, Vanko.
Well, correct me if I'm wrong, but I think that this aneurysm and thrombus extends and involves the whole arch vessels. Is that correct?
No.
There is some extension into the arch, but does not compromise the patency of the arch vessels.
Well, I'm looking at the CT there. I cannot clearly see, but I don't know, because I don't have slices there. But look at the thrombus there. It looks like it's involving
Maybe if I give you,
and left carotid for sure.
let me give you an angiogram.
Well, angiogram is a different story because you don't see the clot there. I can see the angiogram, but you don't want to land with a stent graft in the clot.
But Dr. Gracia, that's
This is
mural,
intramural hematoma.
intramural hematoma retrogradely dissecting from that perfed
Right.
aneurysm segment into the past surgical site. So I don't really think that it's an extension of the aneurysm, but rather just the hematoma discurring, which usually after we repair it will regress.
So that wouldn't be a concern because to your point, Zvanko, you're right, we don't want to put a graft in
Right,
thrombus.
so
But this is,
if there is a thrombus there, and actually there is an aneurysm with thrombus, then you have to, I would then do a hybrid procedure, basically midline sternotomy, or you could go access laterally there, debranch all the vessels, and then put a stent graft retrogradely all the way down to the celiac artery. Another option that you could do if those vessels are involved, carotid and subclavian, left carotid, subclavian, you could do a carotid to subclavian bypass and do chimneys further down and put a stent graft distally. Those are the other options.
So two considerations, Paul. One, yeah, I think you have a landing zone at the subclavian, and hopefully you'll be able to get away with it. But if you do cover that subclavian, if you see the vertebral on the left is more dominant, and you can hardly see the vertebral. So whenever you're covering subclavian, you need to do the vertebral angiograms, make sure the basilar arteries are connected and stuff like that. One.
You can see it's a big left
vertebral on the
vertebral.
left.
It's,
Yeah.
and the right one is non-existent,
Yeah.
so it's mandatory. You have to preserve it somehow.
very large vertebral.
The right has got huge vertebral too. Yeah, actually the left is smaller than the right in terms of vertebral.
Right, so that's
The
favorable.
second thing you have to consider is this patient had hematemesis, or hemoptysis.
Yes.
So there's a possibility that she has an aortobronchial fistula.
Well, that's why, again, we did the workup by our GI guys beforehand, and the CT certainly was not suggestive of a TE
So
fistula.
we did our first series of aortobronchial fistulas treated with endografts, and actually they do very well. Aortoesophageal fistulas are a totally different ballgame altogether, but aortobronchials with endografting is a very viable long-term solution.
Okay. What about our Dr. Asher, Dr. Grayson? You guys got any comments about how to proceed?
So, yeah, I think that most reliable long-term treatment is to do a circ arrest and go in and repair that. And the arch isn't involved with the hematoma, the dissection's going to be, but it's narrow and you can work with that. And you could probably sew flush with that subclavian, and if you didn't feel you could do that, you could do a bypass to it. But in a 48-year-old female, that's probably the most effective long-term, but it's a bigger thing. I'm also amazed, though, at how the aorta remodels with endografts with these dissections. It's quite remarkable, actually. You can put an endograft in. The point was made that this is all the visceral vessels come off the true lumen. But if you land it, if you do there's not much distance between the carotid and the subclavian here. So if I were going to do it, I'd probably, I might do the carotid subclavian bypass. I might just lay it in the aorta right at the orifice of the subclavian, sort of close, and then if I needed to snorkel that, do that. But the problem with the endograft approach is we don't have as much long-term information. So you're guessing at sort of what you're going to do. And could you probably make it work? Yeah, you probably could, but you don't have any idea what the percentage of them that are going to work and what's going to happen downstream. But I will say that it's the ability of the thoracic aorta to remodel, when we look at that, is actually much better than the abdominal aorta. And we see some quite large dissection things like this. And by the way, I don't think this is acute, this is chronic. We see some quite large ones like this, which over time just disappear. It's amazing, really. Anyway.
Yeah, I'll second pretty much everything that anyone said, but I'll add, remember that this patient had a hemiarch procedure for the original treatment. They didn't have just a standard.
I think it was
type-
Grayson, I think it was just a tube graft.
No, it was a
No,
hemiarch.
no, it's a hemiarch.
Is it?
Yeah.
Yeah.
So,
look like it.
well, I know it doesn't look like it, but
According to
that's
the
what
op report we
presentation
got
was.
from the outside institution.
Yeah, it doesn't look like it on this shot, and it doesn't look like it on the CT scan. Just because someone says they did a hemiarch doesn't mean they did a hemiarch. It doesn't look like it.
I agree with you.
Noted, gentlemen. I can only go by the op report, though.
Well, I mean, you can see the anatomic, you can see the distal suture line there proximally innominate, which anatomically looks like a type A tube graft. But presumably, if they had a hemiarch, you know, then you're going to be able to land this graft basically at the kind of the inner curve or under edge of that surgical repair right underneath the left subclavian artery. So there's really, from long-term standpoint, there's two aspects. One, is there going to be a need for long-term arch intervention by leaving a segment of untreated arch? That could be treated, I guess, with a open surgical repair and circulatory arrest, completely replace the arch and then descending. And then the second would be, so what happens to the arch long-term, and then the second issue is what happens to the descending thoracic aorta and distal issues. With an open surgical repair, you're not going to do a total thoracoabdominal replacement with reimplantation in this patient, but you'll probably just go down to the, the diaphragm and above the celiac. So I see that endovascular options are going to be pretty feasible in this, and that there will be still some downstream manifestations, but a lot of those would still be evident even in a standard left thoracotomy and surgical repair of the descending thoracic aorta.
Great comments from all. And I just got a little notice that my time has been cut tremendously in half. I was told to extend this. Now I'm trying to shorten this. So, but anyway, again, I think great discussions here. The issue about hypertension and its contribution to this pathology in the young African American populations, no question. But it's more than just that, because we see a lot of hypertension in African Americans, and they don't have this pathology. Secondly, I think, Vinny, you brought up the point of the importance of the vertebrals here. Again, very, very important before you decide landing your grafts and intervening here. You got to identify that. And actually, the vertebral here comes off the arch on the left side. It's kind of a little misleading here, but it actually comes right off the arch here. But the other question, as you can see, some folks, in light of her age, surgery certainly is a reasonable option. Endovascular approach, certainly a reasonable option. You can get into the debate about the risk of paralysis in a young person, and that might sway you to the left or to the right. But again, with this particular patient, we decided that an endovascular approach was feasible.
So when you have selected your option of an endograft, then there are other considerations, right? One is base springs, no base springs.
Say that again now?
Sizing. So what considerations do you take when you do dissections with endografts?
So again, you guys are going to have to give me a little bit more time because these are very important points here. Sizing, how do you size an endograft in this particular pathology in contrast to de novo aneurysmal disease? Again, I think, Miguel, you commented on sizing earlier in this. But the point is, I think you don't want to oversize. It's significantly so, maybe 10%, but you really don't want to get in the business of significantly oversizing the graft, and certainly you want to size to the relatively healthy segment of aorta here, which is, I think in this patient was about 31, okay? And we chose a 34 millimeter graft for this particular patient. Moving on, this is, whoa, how do we get to that?
That's the end.
Whoa.
That was fast.
I think they just cut me off. I don't have an option here, but there's a lot of interesting points here in this particular case. Again, we chose two grafts. One, again, was the Gore CTAG device. Was a 34 by 20, and we extended it down with the second device because the next question was, how far down do you go? And after we placed one device, we still had significant retrograde flow into that false lumen. And again, I think one of our endpoints, obviously, is to try and minimize flow to that false lumen. So we extended the graft, and as you can see here, we laid it right at the level of the celiac artery there, maintaining patency of that celiac, and pretty much isolated any significant retrograde flow. We did not post-dilate this with a balloon, which also, in terms of technique, is something I think we do differently compared to non-dissected pathology. And I'll leave it open for questions at this point in time.
So the problem of treating younger patients is the acute angle of the isthmus. So younger patients, the subclavian aortic angle is very, very acute. So you get this typical bird beaking for these kinds of patients, and that's something to consider when you're doing thoracic endografting for aortic transections and even for acute type B dissections or chronic type B dissections. So if you look at that bird beaking of the graft, you can see it's almost headed towards the left carotid almost. So that's one thing companies need to know is how to get that graft down to seat at the bifurcation.
And that's an excellent point, Vinky, but I think in this particular case, and I think this is one of the advantages of the CTAC, if you look, you got a little bit more conformability than you do with some of the other grafts. But that's certainly something you have to be cognizant of.
One quick point is that, I think, again, this area really should be treated with branch graft technology, and this is, the single side branch or even the double branch graft with the Cook system is actually looks like it actually has a tapered stent which will actually conform to the arch. So I think these will be, treated, well treated in the future with these branch grafts, but I think this is a great result. I mean, you got a very nice apposition proximally and got a good seal.
And she did very well. It was all done percutaneously. She went home post-op day 4. We left the spinal drain in for 2 days. That was always another topic of discussion, how long, and it did incredibly well. So again, we can talk about this really endlessly, but let's move on with our program.
Very nice case. All right, for last case, or last talk, Dr. Milner is going to talk about complications. Thanks.
Thank you, and thanks again for having me. As Paul said, I'm right down the street from him at the University of Chicago. My disclosures for this you see here and will be relevant to some of the complicated anatomy that I discuss. We talked about this a little bit earlier in the prior session. EVAR's gone through dramatic changes over the time frame since the FDA approval of devices. This was taken from a publication in the JVS a little over a decade ago now, and every lightning bolt there shows you when a device went off the market, and some of those devices were able to recover and come back, but some did not, and we've learned a lot, and we continue to learn, and I will share some of that with you. I think really the way that I think about managing the complications is a lot of it can be prevented with appropriate pre-case planning. Even with great planning, we still run into unexpected problems. And then surveillance, obviously, to identify some of the long-term problems, but I'm going to focus on acute complications today. So when you look at early versus late, I think it's important to understand the difference between the two, though. The early complications we need to treat and understand are endo leaks, both the cause and then the intraoperative management, unintentional vessel occlusion. I'm going to focus mostly on renal when I show this, but Dr. Reed did a nice job talking about the importance of preserving hypogastric arteries. Clearly, arterial ruptures that occur during the case, not just from delivery systems themselves, but when we balloon, sometimes inadvertently in the top of the aorta and the top of the endograft, if we're not careful, you can cause ruptures in the non-aneurysmal area. When you look at late complications, a lot of things can happen to devices into aneurysmal disease. We heard earlier, we discussed at length, aneurysmal degeneration of the neck that can occur with devices specifically. There's risk of endo leaks, aneurysm enlargement, rupture, limb occlusion, kinks, integrity of the device, migration, aortic neck dilatation. We talked about infection already, as well as aoroenteric fistula. So the 4 aspects of early complications that I'd like to focus on are endo leaks, unintentional vessel inclusion, ruptures, and arterial injury. So when you look at endo leaks, I think it's pretty easy to classify what we need to do and think about. Clearly, type 1 and type 3 obviously need treatment. But I put that there with a slight caveat that I think a lot of us, when we trained and in our early experience with EVAR, were taught the adage, never leave the operating room with a type 1 endo leak. And I think many of us have started to learn a little bit when we can leave the operating room with a quote-unquote small type 1 endo leak. And I hear that a lot when people talk about this, and it's sometimes hard to know when it's small or when it's okay to leave it. But I think when we've gotten to the point that we've been as aggressive as we can on a given day, and additional adjuncts are going to have significant patient risk, and further discussion needs to be held with the patient, we sometimes will leave type 1s and see what will happen. And some of those will seal, especially in very calcified anatomy and at times in tortuous anatomy. Type 2s clearly can be observed. Dr. Hussein's live case earlier today was a great example. That was actually a fairly large type 2 endo leak. Dr. Ramaya and I have a disagreement. I think that one's not going away. He said it is. And I think type 4 is very rare. So I'm going to show you a case of mine from a while ago that had a type 1 endo leak, that even in anatomy where I didn't expect it was going to happen, this is a relatively straightforward endograft in my mind. The right renal's a little bit lower. I thought I initially placed the device fine, but you can see a fairly significant type 1 endo leak. Here you see where that device is much lower than I wanted, able to place an aortic cuff. In this case, I had enough room to get some extension here up to that right renal artery. And even despite doing that, although it's not obvious to see here, these are in the days when I was still putting in pressure sensors and my pressure was elevated still, and I knew I did not have an appropriate exclusion, and went ahead and placed a Palmaz. Now, I will tell you that my paradigm on this has changed dramatically now. I almost never place Palmaz devices because if I get into a circumstance where I just don't have a neck that I can gain seal, I usually will think about doing something off-label, such as a snorkel approach. But in this case, a number of years ago, I did put a Palmaz in here and got appropriate exclusion. I think for anybody who's going to do complex endovascular interventions, especially complex aortic interventions, it's critical to know how to deploy a Palmaz and know how to use it appropriately. I think some people learn on the fly, and it's a tough technique to learn on the fly because it can be hard to deploy accurately. So we heard a lot also about different technologies, both from Dr. Mariah and Dr. Krazier. Clearly, we've gotten indications for shorter neck IFU down to 10 millimeters for some devices and even smaller, 7 millimeters potentially for trivascular, as they say. Fenestrated devices give us neck options, 4 millimeters for the Zenith fenestrated device, and Chivar clearly expands our indications. Accurate deployment mechanisms, which all the devices have gotten much more accurate in our deployment, can help deal with type 1 endo leak prevention. And then, although I don't personally have experience using it, the staple technology in the literature and with anecdotal experience has been very valuable for resolution of type 1 endo leaks. So how about unintentional vessel occlusion next? Again, really, I think some of this can be prevented with appropriate preoperative planning, but at times, even with imaging that's done in the operating room, we don't always identify the origin of the vessels appropriately, don't correct for our cranial caudal correction or obliquity to be able to see the vessel origin perfectly. This actually was stolen from my colleague, Dr. Krazier, for presentations that we do for one of the industry courses, and this is showing a renal artery occlusion, and here is a circumstance where in very challenging anatomy, the left renal artery was occluded. This was salvaged with a endovascular approach from an upper extremity where a stent was placed. It's written here, try to pull the device down. In my experience, the ability to pull a device down when you have something like this happen is really challenging to do. And usually what you see is the entire aorta and device coming down, and then when you release the balloon, everything goes back up to where it was before. I think when the devices are appropriately fixed in place, it's difficult to get them to move distally. Clearly, if you can't successfully salvage a covered renal artery with a stent approach, surgical bypass is an option. Rather than maybe doing a full conversion, which is listed here, you can do an extra anatomic bypass to a renal from an iliac, or wherever that you can do it to salvage that iliac, to salvage that renal. But this is something that you have to be careful of and prevent. Again, when you look at improvements in technology, I use the same side duplicated here. I think this helps us prevent unintentional vessel coverage. This will show you as we look at the benefits of some of the different mechanisms of deployment with the C3 delivery system for Gore. Here's a case where I was relatively aggressive with the neck, knowing that I could be with the C3 mechanism available, and you can see coverage of the right renal artery here, which there's still flow, but you can get the sense that the fair bit of that artery is covered. I'm able to move that device distally. Tried to show you this where I changed the device but not the anatomy so that you can see the device has come down from where I had it initially deployed over the right renal artery. and in a completion angiogram where you see no evidence of an endo leak and both renal arteries patent. So technology does continue to improve to deal with this, and although we want to always avoid this complication with more challenging anatomy than many of us are seeing, it's really a critical part of what we do to be able to avoid covering renal arteries. How about ruptures? We all hate this. It can lead to really not just life-threatening complications in the operating room, but even when you get patients out of the operating room, very difficult management post-operatively. The device delivery profile has significantly improved, which helps us prevent this, but again, some of the challenging anatomy we see puts us at risk for developing these complications. This was a patient that I met after having an endograft attempted at another institution in town. I don't truly know where. I'm not just hiding it to protect people here. But could not get the device placed, and actually the stent you see in the right iliac system is from a dissection that was created. So she came with the hope not to have an open repair, and honestly, as we were having a debate before with the type B dissection patient, whether or not open or an endovascular approach would be better, even in this patient, this is a very challenging open surgical procedure. Super calcified neck, super calcified iliacs. This is tough to clamp and sew from a surgical perspective. So when I looked at this, although it's a very challenging EVAR case, the surgical approach to this is not very straightforward either, and an almost 80-year-old patient is fairly high risk. Here you can see fairly significant neck angulation as well. Was able to get a device in, but you can see the access is pretty challenging. And I did have initially a type 1 endo leak proximally, and I was going to try to treat this with a cuff, but I could not advance my sheath back into the device and decided to go bareback with a cuff, which did not work out well, and the cuff got stuck in the iliac. And in my intelligent maneuver of thinking, oh, I'll just open up this cuff with a balloon expandable covered stent, I created this, and thankfully with Viabond technology was able to salvage it. I show you this partly because you can see the device in the retroperitoneum, but you can see the salvage that was used with the self-expanding covered stent. And as you pre-case plan for difficult iliac access, especially more with TVAR than with EVAR, you need to have self-expanding covered stent technology available. As much as I like the ICAST technology and use it a significant amount throughout my practice, I think when you have a vessel rupture, the self-expanding stent technology works better to seal that. You never want to see this. This is from a patient of mine in Atlanta a number of years ago. Unfortunately, we all intermittently have had this happen when we deal with very complex anatomy. It's an iliac artery on a stick, plus my iliac artery on a towel. I just didn't want it on a stick. I figured a towel would be a nice picture as well. So conduit use, you can use it during EVAR. This is a little self-propaganda from Endovascular Today publication that I had. I think it's pretty rare that we need this, especially as the delivery systems have continued to get smaller in profile. But I think for someone who's a very poor surgical candidate from an open aneurysm repair standpoint, if you really cannot get a device in, that a conduit is not inappropriate. And you can also consider endoconduit use. This is a very small iliac treated with a Viabond to be able to get a better lumen. And then another option is a true endoconduit, where in this patient who did not have a patent hypogastric artery, you can stent all the way up to the aortic bifurcation, and you can see at the bottom part on the right-hand side of the screen that there is surgical exposure there, and basically stented down to almost a surgical exposure to get a device in. How about arterial injury? So we talked a little bit about PVAR already, as Dr. Ramai mentioned. Surgical cut down is an option. I think for those of us as surgeons, we still do a mix of both in our practices. I think, again, patient selection is key. And here is a patient with fairly significant posterior calcification, but you can see a very soft anterior wall of the artery, which is an appropriate candidate for PVAR. So who's not an appropriate candidate for PVAR? This lady. Especially not early on in your experience. I think you can do this with PVAR, but don't do this as your first case. And again, this iliac tortuosity, although it's not terrible to navigate a device, it sometimes makes getting the initial perclose in a little bit challenging and would not be the one I would recommend as your first case for PVAR. So in conclusion, I think pre-case planning is crucial. For acute complications, for your long-term complications, surveillance is obviously critical. You need to understand what problems can happen when, and then be able to identify and treat. And then, as those of you in the audience who know me well, it's impossible for me to give a talk, and especially being a good Chicagoan, without sharing the Blackhawks once again. So Thank you.
All right, excellent. Thank you for all these wonderful talks today, everyone. So we're done with this session. Just a reminder, there's 2 lunch symposiums that are going to start shortly. They're downstairs. Lucerne 1 will have a Gore symposium on the Reline study, and Lucerne 3, Avenger, will talk about the luminovascular technologies. So I invite you to check that out. We'll be back here. When are we going to be back here? 1:15. Thank you.